medical staff leaders are really tremendous leaders and healthcare organizations in our communities. And we thank them for the work they've always done, but especially over the course of the last 6 months. Our frontline leaders are doing great work as well, and they're taking care of patients in all of our hospitals across Kansas City. They're taking care of COVID-19 patients. They're making sure that we have the safest environment for our patients and for our staff. We're also taking care of a lot of other patients. We're trying to make sure that we are meeting the needs of anyone who has a healthcare need in our city. We know that hospitals are providing a lot of inpatient care. We have a lot of patients in hospitals across the Kansas City area, but we're also seeing a lot of patients in the clinics and in the ambulatory settings. They're doing this by telemedicine as well as face-to-face visits. Today, we're here to talk a little bit about the COVID-19 challenge that our region faces. You'll hear from these chief medical officers here very soon from several hospitals and health systems in our area. They'll talk about what we need to do to stop the spread and to slow the spread of this disease and this virus. They'll talk about facts and data and information. They'll share some information about what's going on currently. We can also talk, and we'll hear them talk about what we can do to change the current course. You'll also hear from some local business, civic, and educational leaders about why this is so important and what steps we need to take to change our current path. Many thanks to each of you for tuning in today, and many thanks to all of you who have supported this community, your leaders in this community. We know that we need each one of you to help with many things, and certainly with COVID-19 as well. We know there are no easy answers, but certainly coming together in this really collaborative fashion, we can absolutely make a difference together. And now I'd like to introduce a friend and a great leader in the community, the Mayor and CEO of the Unified Government of Wyandotte County and Kansas City, Kansas, Mayor David Alvey. I'll turn it over to you, Mayor Alvey.
Thank you. Thank you, Tammy. And thanks to all of you who have joined us here this morning, for a very important event. Our audience includes healthcare professionals, business leaders, and elected officials, including the chair of the Johnson County Commission, Ed Eilert, the mayor of Kansas City, Missouri, Quentin Lucas, and Jackson County Executive Frank White. Welcome all, good to see you. Now, even though our audience today includes many who hold public office, today's event is not really about politics, and it's not really about policies or mandates. It's really about education. And so today we want to hear from a group of chief medical officers, CMOs for short, from a number of our area health systems and hospitals. Our public health officials have done an outstanding job during this pandemic. But the experience of a chief medical officer is distinct from that of our public health professionals. The CMOs you'll be hearing from shortly will share their experiences from a hospital's standpoint. It's from the front line, if you will. Today's event aligns with the message we received just a few weeks ago from Dr. Deborah Birx, the coordinator of the White House Coronavirus Task Force. Dr. Birx had met with leaders in Florida, Louisiana, Texas, Arizona, California. Those states were in the middle of uncontrolled spread of the virus, and they were implementing more vigorous measures to regain some control of the situations in their states. Dr. Birx had also been meeting with leadership of the northern neighbors of those states, Kentucky, Tennessee, Arkansas, Oklahoma. They were then in the path of uncontrolled spread, and they also were asking what they needed to do to control COVID-19 to protect their residents and to keep businesses and education and our daily lives moving closer to normal. In her message to us, Dr. Birx related the tremendous stress that uncontrolled spread had brought to a state's healthcare system, to emergency medical providers, to community healthcare providers, to business leaders, educational leaders, to families. Dr. Birx clearly advised that Kansas and Missouri would see the same trends of spread and experience those same stressors unless we learned lessons that all the others we're learning. And the most important of those lessons is this: take control, implement measures to get to the green zone, or the virus will take you to the red zone. The red zone level for states is a positivity rate of 10%. Just 2.5 weeks ago, Kansas was at 9.9%. As of today, we are at about 16%, and Missouri is at 13.4%. The virus has taken us to the red zone. So here we are. Either we get greater control of the virus, or the virus will take greater control of our health, our economy, our daily activities. We can get to the green zone. Our people, our businesses, our leaders can do this. Again, thank you all for joining us this day. Now, let's hear from our panel of chief medical officers. If you've watched the University of Kansas Health System's morning updates on COVID-19, then you've already met today's moderator, Dr. Steven Stites, Chief Medical Officer for the health system. Dr. Stites.
Mayor, thank you very much. Thank you for helping us put this together. You know, a number of months ago, as a group of CMOs, we started a journey. And the journey was working together on a conference call 2-3 times a week to try and think about how we can work together, plan together, and help together the health of our patients and our community. And I think that has been truly great. We have worked very hard at trying to put together ideas and helping each other make sure our patients stay safe. A few weeks ago on a call, we hatched this idea. What happens if we came together and sent out a note that said, gosh, come listen to us because we have a unique experience, much different than public health officials do, and much different really than what others may be talking about. We're sort of an apolitical group. We're just here to take care of patients. Chief medical officers are involved in the quality of care and making sure that that care gets delivered to patients every day in hospitals and health systems and ambulatory clinics across our community and across our country. Our message today is based upon our unique experiences of what we are seeing about the toll of coronavirus. We know that people have what we've coined the term cows, COVID weariness syndrome. We got a lot of cows. It's not cattle. We got a lot of cows. Because people are tired of having to wear masks. They're tired of not being able to get together in groups. They're tired of not being able to go to football games. I want to go to the Chiefs home opener. I had tickets, not going this year. Why? Because of coronavirus. Be trying to make sure that we all stay safe. And the way we keep each other safe is to follow those pillars of infection control. So today, you're going to hear that story. And Dr. Birx came a few weeks ago. And on that next slide, you'll see she did indeed share a sobering message with all of us. And Mayor Alvey highlighted that message. But I think what she told us was, you don't want to be the Southeast. You don't want to be Georgia. You don't want to be Florida. But you are headed that way. And if you don't do something, it's going to compromise your ability to deliver care. And we know that that's the case. And we know that that's part of the reason as chief medical officers, we came together to talk about this today because we thought we are uniquely positioned to feel the pain of our patients directly. We have zero ties to industry. We have zero ties to politics. We're just here to tell you what we think is the truth. And we think we can help keep each other safe by sharing that message with all of you. I know a lot of folks just believe it's not that bad or that they're not going to get it, but it's just not true. And so on that next slide, we see what the message really is from the chief medical officers, from our different perspective, our different skill set that we have. And as Dr. Birx told us, because, you know, she went out and drove around Kansas City. She drove around the area and she said, y'all don't wear masks. And she has a little bit of a Southern background. So she may have said, y'all don't wear masks. You're not really trying to socially distance the way you should. Your group gatherings are way too large. As she put it to us, wear a mask indoors and outdoors, group gatherings of no more than of 10 or less, and trying to make sure you keep each other safe will help prevent you from going down the wrong track. So today, that's really our conversation. And so if we see our next slide, those are the key message points that we convey a sense of urgency. And so we're going to talk a little bit about what the opening of schools has meant. We're going to show you day to day about what the opening of the University of Kansas has meant to that community and what can happen when a few events turn into a wider spread. We're going to talk about what a strong, comprehensive response means, because we want this economy to stay safe. You know, in April, the cleaners I've been going to for years closed. The restaurant I love to go to closed permanently. We see the impact every day. We are not public health officials. We're not going to recommend public health policy, but we are chief medical officers who see the pain and the toll this takes on our patients and what it means with their families. And we see it all the time in our hospitals. And there is a pain that goes with the coronavirus that is unlike anything we've ever seen. And it is much, much, much greater than the pain of influenza. Influenza is bad, but it doesn't hold a candle to what coronavirus has done. We may at one point have 25 patients with coronavirus. We have 60 people around here that have COVID right now, or have had COVID and are recovering in the hospital still. So these are real things that we visit with every day. So as we begin to go down the discussion with the CMOs, I'll introduce each of these chief medical officers, and they're going to each talk a little bit about their experience and what the pillars of infection control mean to them. The first person is Dr. Raghu Adiga, who's this chief medical officer at Liberty Memorial Hospital, or Liberty Hospital in Liberty, Missouri, and is an infectious disease physician himself. So in our next slide, we'll see what Dr. Adiga has to say. Raghu, you're up.
Thank you, Dr. Stites. Okay, thank you, Dr. Stites. Thanks for inviting me to speak today. Pillars of infection prevention. These are the most simple things that we've known for a number of years. Wear a mask, keep your distance, and wash your hands. These are very basic, simple ideas everyone knows, and they have stood the test of time with the respiratory infections. However, what's hard is being consistent and keeping it up for the long haul. At our hospital here at Liberty, we've seen both the benefits of following these principles when you do it right, and we've also seen what happens when people are not following through. I mean, for example, when it's done right, the employee clusters and institutional outbreaks don't happen, and that's the good thing. And when you see through our doors, we've seen plenty of patients come through now with COVID acquired at indoor gatherings, and people who just aren't really consistent in wearing the mask in public, and that's not a secret at all. Next slide, please. Now, talking about the children, as Dr. Stites alluded to, as we have more and more opportunities for school reopenings and youth sports, this is an area that becomes more important and is evolving as more and more data is coming in. Children are not immune to COVID. Yes, those under 10 seem to be spreading less. However, children 10 and above, as they reach the adult height and adult lung volume, seem to spread just as much as the adults. And the new data from American Academy of Pediatrics that came out this week seems to show that children, especially older children, are currently the fastest growing group of new infections and hospitalizations. We've had a few of those patients in 20s and 30s in our hospital, and we've seen it, how sick they can get as well. And of course, they do spread it to the adults whom they are in contact with. We need to still continue to support our stool authorities when they're being asked to make such really hard choices when the community we all live in have not actually done so. And it is a really difficult task. And as chief medical officers, we know how hard it is, and we are fully with them in making the right call and continuing to take all precautions as we have more and more interactions. Thank you.
One question I had for you, just to think about it for a minute. Can you imagine a place where the risk of COVID spread is higher than a COVID ward in a hospital where you know you have patients who actively have the disease? Is there a place that you can imagine that's more likely to spread the disease, or the disease to be spread?
Well, of course. I mean, any place where you can have that much gatherings, really. I mean, the schools and any other community gatherings, I've heard of plenty of places where it can certainly happen.
Yeah. What I'm fascinated by is here we have these hospitals, and we're all represented today with COVID patients in COVID wards where we put our patients who are actively infected, yet we're not seeing spread of disease in the hospital. Why is that, Dr. Adiga?
Exactly. I mean, that's the beauty of taking precautions. I mean, you can see not a single nurse, single staff here walking around without a mask. In fact, you should come and see how they take breaks. each person, when they are taking a break now, when they are having their masks off to take a drink or food, they're by themselves. And for a short period of time, there is nobody near them. And we have really driven home on the importance of it. That's how we don't see any spreads here. In fact, we do have a long-term care facility that we are managing as well. And we've had some employees who've been positive acquired at the community. But to date, we have not had a single resident catch the infection. Why? Because we strictly drive home the importance of all these infection control principles.
Yeah, exactly. The hottest spots in the country are in hospitals because they have wards of COVID patients, 30, 40, 50 patients at a time, and we're not spreading the infection in hospitals. Why? Because we follow the pillars of infection control. And I think to Dr. Steele, who is our colleague at Truman Medical Center, as the chief medical officer there, that's incredibly important. Truman serves a very special population. It's an underserved population. It's a population that has to remain employed. And Truman has done a remarkable job of putting out pop-up clinics and other things to try and identify where patients are sick to help prevent the spread. Dr. Steele, you have some important thoughts and messages you want to share with us today.
Yes. Good morning, Steve, and thanks for having me. So obviously all of us play an important role in helping to stop the spread of COVID. And Dr. Adiga talked about the importance of social distancing and mask wearing are two main weapons currently to help prevent the spread of COVID. I thought I might just mention a couple of case studies that further highlight how effective mask wearing can be. The first is actually the Great Clips story that was out of Springfield, Missouri after they reopened there. You may have read about this. A couple stylists became infected and potentially exposed 139 clients with whom they had close and prolonged contact. The stylists and the clients were all required to wear masks, thankfully, and none of the clients became infected. In another recent report out of South Korea, an infected individual spent a couple of hours in a Starbucks drinking coffee and talking to friends, and 56 other individuals there at the same time doing the same thing ended up becoming infected. However, there were 4 Starbucks employers working then who were wearing masks the entire time and did not become infected. So I think a couple of fairly compelling stories about how important it is to wear masks to help prevent the spread. Here at Truman, we are absolutely very strong believers and supporters of mask wearing and have required all of our employees to wear them since very early on in the pandemic. We've also been out in the community a number of times distributing masks and also performing testing. Another point I wanted to emphasize is the need for employees who are ill to stay home from work so as not to spread the infection. As you know, employees may be reluctant to stay home when ill if they will be without income, have to use PTO, or have concerns about their job security. Truman changed its policy so that the employees don't have to utilize PTO for this purpose up to a maximum number of hours to help encourage them to stay home if they're sick. In terms of what we've seen here at Truman, when our COVID hospitalizations were at their peak about a month ago, and we were approaching returning to our pre-COVID volumes, our COVID patients occupied a little over 10% of our total bed capacity. This obviously put some strain on our system and on our emergency department, where we ended up intermittently holding a number of admitted patients in our emergency department. We've also seen firsthand how this pandemic has disproportionately impacted our minority communities. And as such, we have aggressively been out in those high impact zip codes and communities providing prevention, education, and testing. We've also witnessed some sobering young deaths from COVID. We had one person being in their mid-20s and a couple of deaths in their mid-30s.
People do get the disease. And Mark, I think the other great point here is that in a community that is and largely a minority served population, you're still not seeing the spread of the disease inside your hospital. And the reason is the same thing as we heard from Dr. Adiga. Good infection control policy works. It works at Truman. It works at Liberty. It works all across our city. Thank you so much for the great work you're doing. You know, one of our other colleagues is Dr. Stewart, who's the chief medical officer at North Kansas City Hospital. Dr. Stewart and his team have done a great job. They had a pretty significant number of COVID patients, but have kept that in check by also following those same policies of infection control. Dr. Stewart, help us understand where things are in your hospital and the fear and concerns you have.
Thanks for having me today. I want to talk about young adults and their social gatherings. They need to understand that these can turn into a major source of outbreak. and cause a resurgence of the virus. And it's important to keep reminding them of the importance of preventative measures of mask wearing, of social distancing, limiting size of gatherings, and hand hygiene. But one thing that they often don't realize that these recommendations aren't just to protect them and keep them safe, but it's also to keep their family safe, their parents and their grandparents. We recently had 3 members of one family in the hospital at the same time. The son was infected, and then both parents got admitted to the hospital and even required intensive care during their illness. So it's important to emphasize to them that these measures do protect them, and the risk to family members is real. Even if they don't have severe disease, their family members could get severe disease. So it's important to be vigilant, to stop the spread, to protect your family, and to continue to focus on the infection prevention measures that we know work.
Very much, and boy, is that ever true. And talking about college campuses, we're going to hear now from Jen Scrimshire. Jen is an infectious disease physician at Lawrence Memorial Hospital in Lawrence and has been part of our pandemic response team to help prevent the spread of COVID across the University of Kansas campus as it reopens. We've taken a lot of steps at KU, including mass testing of the 25,000 students who came back, as well as the faculty and staff, because we saw that as a mass migration and the potential to really develop an incredible hotspot and affect the health and lives of people throughout the Lawrence community and Douglas County. I want you to hear from Jennifer, because we want to talk about that experience in Lawrence, which I think informs us all of what happens when a campus reopens and how difficult that can be. Dr. Scrimshire.
Thanks, Dr. Stites. I think we've been fortunate for many reasons in Lawrence, but one is that we've been able to view it as a microcosm of the pandemic at large, and a couple of lessons to be learned about community responsibility and public health measures. As you can see from the graph, I was proud of the Lawrence community. I mean, we had next to no cases for the longest time. I mean, we were just really stagnant because people stayed home. They did what they were told, mitigation measures as far as masks and staying away from others. We did have an influx of people into the community, and we saw a sharp rise. I mean, we had hundreds of cases over a very short period of time, but we realized that this was primarily what would be considered a super spreader event related to the bars. So Dr. Marcelino, who's the health officer for the county, instituted a mask mandate for all residents in public in Douglas County. And then we ended up closing the bars. And as you can see, we had a sharp drop off shortly after that, finding that the spread was related to bars and people in the bars. And then the next rise is with KU students, which we expected. And the rise that you see on the graph, I don't want to mislead anyone and think that this is just students coming back. I mean, we were intentionally testing students. So several physicians on this panel and a large group in Lawrence, University of Kansas, KU Med, Douglas County Health Department, Watkins Health Center, we're all involved in this KU reentry testing strategy. So the initial, like I said, was testing upon reentry. So this was more of a prevalent study, finding that probably around 2% of students returning were infected as they returned to Lawrence. But as we moved forward, it became more of an incident study. So we were seeing local spread between students and watching these numbers rise. But we were able to implement what we call test and trace. So we're testing people, tracing their contacts, going to high risk areas, testing those folks, and really getting that under control. So this is the next drop off that you see, success of public health measure. This, is directly related to the influx of KU students, but these students are integral and an inseparable part of our community. Although they are somewhat separate, they represent a burden of disease within our community that can continue to spread. So it was very important that we implemented these measures to try to find those infected people and control what we could. We've been fortunate at Lawrence Hospital as far as the impact that second peak you see had on our health system. We really haven't seen many hospitalizations related to that, but that is not to say that we have not seen young people come in. That is certainly not to say we haven't seen death, because we've seen plenty. So, and as moving forward, we need to continue to be mindful of the pillars of public health, like you discussed earlier, continuing to do surveillance testing moving forward, both random and for high-risk groups, and continue exactly what we've been practicing to this point, test and trace, and reinforcing our basic mitigation measures. Mask up, keep your distance, wash your hands. I've been thankful for the collaboration. It's been amazing to be able to work with so many people in such a, like Tammy said earlier, collegial, collaborative spirit.
Well, thank you, Dr. Krimscher. And a special shout out to the University of Kansas Chancellor, Dr. Doug Girard, who let us share his information to the community today. That's a really big deal. Doug's a good friend of mine. I just want to say thank you. This is a really important case point, though, because what happened when the community, when Lawrence started to reopen with the students, it could have become a terrible public health problem. But instead, by working hard and controlling it, we think we can make sure that campus stays open, and that keeps the businesses open and it keeps the students open. But because we all work together to make that happen, one of our infectious disease folks, infection control folks, Amanda Gartner, was on the campus and said there's a 99% compliance with wearing masks on the campus. That's amazing. But again, here's the story. When you do it right, you can keep things open, like keeping hospitals open, because we don't spread COVID between the staff and the patients. Okay, but this is true in all sorts of populations. And I want to turn to Dr. Ahmad Batrash, who's going to address our veterans, who really are a higher risk population in many regards. And yet, Ahmad, talk to us a little bit about the shared experience you've had at the VA. On our next slide, you'll see some important messages that Dr. Batrash wants to leave us with. Ahmad Batrash, Chief Medical Officer at the VA Hospital here in Kansas City.
Thank you, Steve, for giving me the opportunity to talk about the impact on our veterans for COVID. As you mentioned, the veterans tend to have more comorbidities than the general population, with history of smoking, diabetes, pre-existing lung disease, and heart disease. That would make them more vulnerable, not only to acquire COVID, but really more vulnerable for severe disease if they get COVID. What we have seen and what we've done here at the Kansas City VA is actually early on in the pandemic implemented population health measures to try to prevent the spread and educate our veterans by implementing robocalls and reminders and follow up several times. And we still are doing this. And potentially because of this and because of the availability of and access to testing that is readily available for our veterans, that we have seen actually consistently less positivity rate, if you will, for our veterans compared to the Kansas and Missouri metrics that we have seen. So our positivity rate, for example, last week, which has been increasing a little bit, like the general population, is 6.5% for our Kansas City VA enrolled veterans. So that's really highlights the importance of education of our patients, making sure that they understand the infection prevention measures. And our veterans tend to follow the advice, which is really, we are very thankful for that. Another impact that is kind of special for veterans during the pandemic is really the impact on mental health. So what we have seen is significant increase in uptick in mental health issues for our veterans since the pandemic started, and specifically an unfortunate increase in the suicide rates even for our area veterans. So that really highlights the importance of consistently and continuing to do the outreach to our veterans by telemedicine and by face-to-face, and ensuring that we pay special attention to the mental health issues and prevent suicides. So screening for suicide risk is really of utmost importance, and that should be done at all encounters when we encounter, again, our patients and especially our veterans because of their risk.
Thank you, Ahmad. That's a really important message. And I think that mental health message becomes incredibly important. You know, again, our goal today is to help to add resolve for our political officials about the disease and the death and the toll that this is taking on human lives that each of us sees every day in our hospitals as a direct result of COVID. Again, it's not influenza. It really is a pandemic, and it's really bad. And Larry Botts on our next slide is going to talk with us a little bit about some of the effects that he and his colleagues at Shawnee Mission Advent are seeing. Dr. Botts is a pulmonary colleague. I've known Larry for many years. He's a great physician. He's the chief medical officer over at Shawnee Mission. I think he has some really important points he wants to make today about the systemic effects of COVID, even if you recover. Go back one slide. We jumped one too many. We should be on the slide titled Long-Term Consequences of COVID-19, Infection or Troubling. Dr. Botts.
Thank you, Steve. And I want to thank you and KC Chamber for providing this opportunity. As we know, most individuals with COVID-19 will recover in a few weeks, but much is still unknown about how COVID-19 is going to affect people over a long period of time. We do have some information from outbreaks in Europe, as well as our experience the last 6 months in the US. And although COVID primarily affects the lungs, there is evidence that it can affect other organs as well. The pneumonia that is also often associated with COVID can cause damage to the lung, resulting in scar tissue formation, and this scar tissue can then lead to long-term breathing difficulties. COVID has also demonstrated that it can cause lasting damage to the heart muscle. This can result in arrhythmias and subsequent heart failure. The brain and the nervous system can be affected, even in young people, which will result in strokes and seizures, and those individuals that have been treated in the ICU on ventilators for a prolonged period of time can also suffer from post-traumatic stress syndrome, depression, and anxiety once they've recovered. And finally, COVID can affect the clotting system as causing an increase in clotting, which will sometimes result in heart attack, strokes, and pulmonary embolism, which is clots in the lungs. As an example, Advent Health had a 51-year-old previously healthy female who developed mild COVID symptoms. Over several days, she became more short of breath, developed chest pain. When she was seen in the emergency department and evaluated, she was found to be COVID positive, and in addition had multiple clots throughout both lungs. She recovered, she was hospitalized, she recovered from her acute illness, but continues to take anticoagulants and has generalized weakness, easy fatigability 2 months after hospitalization. I think this demonstrates that even those with mild symptoms can develop life-threatening complications from this disease. As far as the impact on Advent Health and Shawnee Mission is concerned, I would say this has been a very emotional and stressful period for our frontline workers. And they've been caring for COVID patients as well as our other patients in the community in need of care. Over the last 6 weeks, we've cared for a greater number of patients in the hospital with COVID than any other time during the pandemic, with little increase or decrease in that population of patients over that time. Our biggest concern, our staff's biggest concern, our greatest source of anxiety is that we will experience a surge which overwhelms our system and will be unable to care for our patients. This reinforces the need, I think, to be vigilant, to continue following good infection prevention practices has been emphasized on this call, and including wearing masks, social distancing, and good hand hygiene, so that we as a system and as healthcare providers can continue to care for our community needs. Thanks.
Dr. Botts, thank you very much. And Larry, I always appreciate your work with us and your professionalism and the dedication that you and your team have to your patients. So thank you so much. David Wild is the Vice President of Performance Improvement here at the University of Kansas Health System. David has done a great job of helping head up our coronavirus response. And I think of him as kind of my right-hand guy, and I keep turning to him about all things COVID. You know, there's an important point to be made here. We have not been New York. But don't think that we're not stressed at a hospital level by the impact of COVID right now and what that will do to us if we have a big rise as schools reopen, universities reopen, or people start relaxing too soon. This is a manageable disease, as we have proven by preventing hotspots, hospitals, from spreading the disease internally. We've proven that with masks. And in addition, you know what? Our patients, when they leave here post-COVID, they don't want to stop wearing a mask. They want to keep wearing the mask because they know it keeps them safe. What we also know, though, is that hospitals are very stressed by this. We're all full. We're heading into the flu season. We're heading into the hardest part of the year, and yet we're full, and often COVID is a significant percentage of those patients. David, let's hear from you.
Thanks, Steve. I get questions regularly about the numbers of patients in a hospital, the number of patients infected, how disease is spreading. And for those of you who follow the census number that's shared either from your local hospital or from our hospital on our daily media call, you may get the sense that things are relatively stable, that the census number, the number of patients in the hospital on any given day, has been flat or variable, but not rapidly increasing. And that's true. That tells part of the story, though, about the impact on our hospitals. The rest of the story is told by the graphs that you see here. And so what we'd like to share is this. The number of new patients every day that are coming to hospitals needing hospitalization is higher now, as was just mentioned, than any other point in the pandemic. In the month of August, we're on average seeing somewhere between 8 and 11 new patients per day, compared to even in April when we had our highest census, a maximum number of patients on any day showing up needing to be hospitalized, 6 new patients. So that's being balanced out, of course, by an increasing number of discharges per day. So almost an equal number coming and going, keeping our census flat, but showing that the number of hospitalizations, one of the concerns we've had since the beginning, continue to increase in our community. The next slide talks just a little bit about the time that we have now, the opportunity that we have now to act. We heard when Dr. Birx was here that we had the potential to become something we really don't want to become, an area that's overwhelmed, that hasn't succeeded in continuing to prevent the healthcare delivery system, the hospitals and clinics in their community from becoming overwhelmed. We did a great job of that early in the pandemic, of bending or flattening the curve here in our community. We showed we can do it. We know how. It was not easy. I think everyone knows how hard it was. But the concern now, as you see in the chart here, is the curve of the line, the red line for the metropolitan area for Kansas City. This is new cases, so case growth is approaching exponential. And that's a fancy way, I guess, of saying that as growth speeds up or becomes exponential, it becomes uncontrolled. And that's not something any of us want. As we heard, we're worried or concerned, at least, that if that happens, the impact on our hospitals and healthcare systems that are stressed right now would actually be greater than we could handle. We would have to stop offering non-COVID care to patients who need care for other reasons, take care of those acutely ill at our doors with COVID. And finally, the last slide that I'll share is an attempt to share with you more real life stories about what has happened here at our hospital. You've heard from many of our colleagues across the metro stories of patients and the impact on those patients in their hospital. And I do want to take a second to share 4 very real stories that explain exactly what we have seen here at our place. The stories that I'm about to share of these individual patient experiences are very real. The images and names that you see here are representative, so they don't share any protected or health information of an individual patient. But we've seen a college athlete who needed to be admitted to our ICU 7 or 8 days after testing positive for COVID, complaining of significant fatigue. The concern about involvement of the heart muscle and then irregular heartbeats or arrhythmias for patients with that heart muscle involvement is what exactly brought this patient to us. So a healthy college athlete prior to infection spent a number of days here in our hospital and has significant heart failure as a result of this infection and the involvement of his heart. So much so, in fact, that he had to wear a life vest, so an external sort of device that delivers a shock if he were to have life-threatening arrhythmias, much like an internal defibrillator would in other patients. It's likely over the course of time he'll need a defibrillator, and also likely that he'll never have the opportunity to participate in athletics in any meaningful way again. We've also had a college student, a young female, who had to have a portion of her lung removed, also changing her life forever. Previously healthy, no reason to anticipate that she would end up there because of comorbid conditions or previous lung disease. We've had a number of young adults or younger adults, including one in her early 50s who has been on the ventilator in our hospital for more than 40 days. Her only coexisting condition prior to seeing us needing to be admitted to the ICU was hypothyroidism. And again, will have long-lasting consequences from months in an ICU environment. And we've seen a healthy 60-year-old who had no reason to suspect high risk of disease, who ultimately was unable to oxygenate. So the lungs were unable to provide enough oxygen to the blood and to remove enough carbon dioxide from the blood on their own, that he required the external mechanical oxygenation and ventilation using a machine that you may have heard of called ECMO, or extracorporeal membrane oxygenation. He did not survive that treatment, even the most advanced option that we have. So someone young, again, not in their 70s or 80s or 90s, with very significant disease and obviously consequences for his family that we wouldn't want to see. So those stories are real. I think that message, right, goes along with the fact that patients with COVID showing up in our hospital or any hospital across the metro do stress a system that is already stressed. And it's one of the key reasons that we ask everyone to remain vigilant in the principles that we're sharing today.
David, thank you very much. And COVID is real, and it's real for young people. It's real for old people. It's real for healthy people. It's real. Mayor Alvey.
Thank you, Dr. Stites, and thanks to all the chief medical officers for sharing your data, your insights, and the urgency of our situation. So we know what needs to be done and how we need to move forward. But let's now look to more of the why. Our next speaker is a former school superintendent. He understands the difficult path that our school administrators have had to travel and continue to travel during this pandemic. Dr. Kenny Southwick is now the executive director for the cooperating school districts of Greater Kansas City, representing 31 school districts in our region. Dr. Southwick.
Yeah, thank you for giving me the opportunity to speak, and I'm honored to be with the panel today and have learned a lot. COVID is not a school problem, but it's a problem that's been thrust on all of our schools. We would hope that the numbers would be better than what they are as we're on the eve of starting school. We've had a few of our school districts that have started, and most of them will be in session next week. What our communities have seen with work with tough decisions from our school boards, our administrations, and our staff are really the best planning that they can do to do two things, and that is to keep everyone safe in our community and provide a high quality education that we have for years in the Kansas City region. But this is difficult. Local decision making we've not received a lot of direction from the federal government, state government, and that's okay. We've worked with health departments. We've talked amongst ourselves. We've received opportunities to have discussions about what is the best planning. And the result of that is you'll see a range of services out there with our school districts, all the way from completely face-to-face, made possible because of the numbers of families that have chosen a virtual education, make it, we hope, safe to do social distancing, wear masks, wash our hands, and all those things that we know are important. And then in some of our communities, based upon our numbers, completely virtual. And this is a result of the best planning that we can have. But I want to say this, and I only have a short time today. I started off by saying this is not a school problem, and I really believe that, but it's a problem that we're going to tackle. But we have got to, if we want to keep our schools open, if we want to keep our businesses and our hospitals open and our economy thriving, we have to have a higher level of community responsibility. Schools will not be able to do it by themselves. We can keep people safe in our environment, like the hospitals. We're working hard to do that. But if the times that our people are out and about in the communities, if we don't exercise what we've heard today, we won't be able to keep our schools open, and we'll find ourselves in a situation that we were in last spring. So my pleading is, please know that our administrators and our boards have done everything they can to make schools safe and to provide high quality education, but we need the community's help, each and every one of our communities. I want to thank you for giving me an opportunity to speak. Please support your schools and the work they do over the next couple of months. And Joe, thank the Kansas City Chamber for putting this together. And I'm going to toss this to you now. Thank you.
Thank you very much, Dr. Southwick. And thank all of you for being a part of this morning. The response has been great. We have over 300 participants that are currently in our Zoom room, and then over on YouTube, another 400. So we appreciate you being a part of today. You know, getting our children back into the classroom is important for kids and their parents. I can personally attest to that. But it's also critically important for Kansas City area businesses. The KC Chamber is made up of over 2,000 businesses and organizations across the region. And our members are grappling with requests from their employees asking for reduced time, flex time, or part-time in order to help their children navigate virtual schooling, as you would expect. It's a difficult time for all of us involved. Schools and childcare, for that matter, are really the grease that fuels the wheels of business, and our businesses are struggling. Our economy has been hit hard by the pandemic. In the second quarter of 2020, our economy declined by nearly 33%, the worst decline in modern history. And the second quarter also saw consumer spending falling by nearly 35%. So COVID has hit so many of us hard. Businesses, especially small and minority businesses, are struggling, and in some cases, as Dr. Stites noted, some are closing. So I would say if you're pro-business, pro-small business, if you want our schools and businesses opening and thriving, if you want our economy to continue to recover, then we all need to take personal responsibility. It really is on all of us. The best thing we can do right now to support businesses in Kansas City is to socially distance, wash our hands frequently, and please, let's all of us wear a mask when we're out in our community. Well, we've already heard about the impact on K through 12 education. Metropolitan Community College Chancellor, Dr. Kimberly Beatty, is here now to talk about the virus's effect on higher education and what's happening in higher education here in the Kansas City region. Dr. Beatty, I'll turn things over to you. And Dr. Beatty, I think you might need to unmute.
Thanks, Joe. And thanks to all of the expertise that's on this call and everything that everyone is doing to provide this information. From the beginning, MCC when a declaration of a pandemic had been made, MCC has taken responsibility for our students and our college community. We understand the need to change behavior and ensure the safety of our students and employees. So to that end, here are a couple of things that we have done, and I know many of my higher education partners and colleagues have done the same. We've strongly encouraged a remote, we're in phase 2. We have a 4-phase reopening plan, and we're in phase 2, which requires that we strongly encourage remote work unless functions have to be completed on site. So we have enrollment centers where we are doing that by appointment with all of the equipment in place that I'll talk about in just a moment. But more importantly, this caused us to really look at our policies and what we have in policy. So we've had to develop a policy on remote work. We've made all classes that can be taught virtual. We've trained employees on contact tracing, and as a result, we have a very robust contact tracing program. A face covering is required on all campuses on any site at MCC. We've set up social distancing signage. We've made individual sanitation kits available that have spray with viricides so that if you want to sanitize your area more often than it is scheduled, you can do that and take that personal responsibility. But we have increased sanitation across all of our sites with the appropriate viricides. We also implemented a plan for single points of entry with temperature checks and badging so that we can track all people that are on site. Personally, as a leader in this space, I'm very glad that we made the decision early, and it wasn't easy. It's not easy at all. But now we have to look towards spring, and we will likely make that decision early. And I'm very proud. I just want to end on being very proud of the work that MCC has done to ensure a safe environment that will, fingers crossed, keep us in that green zone.
All right, thank you, Dr. Stites.
I think we might have questions.
Wonderful.
All right, Jill, I bet there are a few questions out there.
We do. Using the Springfield hairdressers as the example, if I'm wearing my mask properly, but I stand less than 6 feet away for more than 15 minutes with someone who is tested positive, do I need to isolate?
Oh, that is a great question. I'll turn to Dr. Adega, our infectious disease specialist, first for an answer to that. Don't forget to unmute, Dr. Adega.
Sorry about that. This is a very important question to understand what it means to be wearing a mask. Most of the masks that we are talking about, people wearing in public with the cloth masks and non-medical grade masks, they are designed to essentially prevent the spread from you to others. So in terms of telling whether someone is at risk for catching it, that means what kind of mask you're wearing. So in the hospital setup where we are making our medical staff wear medical grade masks, that is something that is preventing them from catching. So in other words, if you are within 6 feet but wearing a mask in the general public, that is not considered enough protection to give you a guaranteed feeling that you're not going to catch it. So in other words, when we are looking at high risk exposure, whether you wear a cloth mask or not, we still think it is a high risk if you are within 6 feet and for more than 15 minutes.
There you go. We're always concerned. Jill.
How do we get consistency with city, county, and state leadership around mask wearing and gatherings?
Boy, Mayor, I'm glad I don't have to answer that one.
Well, I think we have to continue with efforts like this. That is to continue to bring the data, to continue to discuss the situation we're facing. I keep trying to remind people, let's pay attention to the virus. The fundamentals of the situation is we have a virus, we're in a pandemic. If we watch the virus, it will tell us what we need to do. And so I think if all elected leaders would simply make themselves aware, gather the data, learn about this, pay attention to the virus, we then can find the political will. But until we are aware of what this is and what it is doing to us, I don't think we're going to muster that political will. So it's very important, it's necessary for political leaders, all leaders, to come forward, take a look at the virus, understand it, and let it tell us what we need to do in response.
And may I just say, we heard from Dr. Birx, don't become the next Florida or Georgia. We see that hospitals are stressed. You saw the data that David Weil presented. So just as a quick point, we have about 25 or 30 patients with COVID here that are acutely ill. We have another 30 who are still recovering. So that's 60 patients, right? We had to take 40 beds. We had 85 semi-private rooms. We had to reduce those in half because that meant we could only use private rooms with COVID. So that's a net impact to our hospital of about 100 beds related to COVID. We're an 800-bed facility. We're always full. We just essentially took 100 beds and changed them because of COVID. What does that mean as we head into the fall and winter season, which is typically when all hospitals have their highest census because of influenza and other seasonal viruses besides COVID? We still have to take care of people who have baseline diseases. If we don't take care of each other during the pandemic, we're going to struggle to take care of all the other diseases you can have. We don't want to be in that situation. We have the power to change that outcome. We've demonstrated it every day in hospitals where we have wards of COVID patients who are not spreading it to staff or spreading it to others. We control the spread because of the pillars of infection control.
What advice do you have for employers who have employees who tested positive for COVID, quarantined for 10 days, and want to come back to work, do they need another test?
That's a great question. I'm going to turn to David. I know, David, we've talked a lot about this, and really after about 10 days, you're not so much of a spreader.
I would agree. So the science would say that we have no evidence that anyone is actually spreading live virus more than 10 days or 11 days at the absolute most as the outlier from initial presentation of symptoms. We also know very clearly that patients can test positive with a PCR test. So the nasal swab that most people, or nasopharyngeal swab that most people are familiar with, for 80 or even 90 days after their first positive test. When we put those two things together, it's very clear that there's not really a role for return to work testing or negative testing as clearance, if you will, to return to work, because we expect that some or even many patients will test positive for weeks or months, but will not be infectious. So for our employers, I would say the 10-day isolation period is very reasonable, assuming, of course, that you are making sure that the employee does not have any symptoms of fever or cough or things of that nature before they return to work.
And Jen, on the Lawrence campus, after 10 days of being quarantined, can people go back to the campus if they're positive?
Yeah, after you complete your isolation period, similarly as Dr. Wild had said, as long as the fever is resolved for at least 3 days, their symptoms are improving, they've completed their 10 days of isolation, then yeah, of course they can go back.
They still should wear a mask, but everybody should wear a mask.
Yes,
Absolutely.
yep.
Children and athletes in particular, if they were positive for COVID, should they have their heart or other tests done before returning to play?
Well, that is a really great question. Let me see. Who wants to pick that one up? Dr. Botts, let's start with you. And then I'm going to turn back over to Jen, because I know we've got a specific protocol for that at the KU campus.
Yeah, that's a tough question. I'm not sure that I can give you a great answer. We don't have a lot of science out there to tell us where to go with this. I think that the way to go from a standpoint of being as careful as possible is that once they have recovered and they're going back to athletic competition, it would be at least a minimum that they return to their physician to make sure that and evaluate them prior to going back to activities. And then any other tests that might be warranted depending on that examination.
It's also something in which the rules keep changing around us, and they change almost every day about what the risk is and how you should return to activity. Jen, we've developed some rules, though, for the University of Kansas. Any thoughts about that?
Well, I think the plan, it's basically an algorithm for an athlete turn positive before they can return to activity. There's multiple tests performed, including EKGs, blood work, an echo, which is like a sonogram of the heart, and in some cases a cardiac MRI. I think this policy or this plan was patterned around other causes of viral myocarditis due to other respiratory viruses. And while we have a plan, I am still very nervous because, I mean, how many months are we into this pandemic? How many months of data do we have? And I don't know that it's enough for me to say that folks will be fine regardless. It still makes me uncomfortable regardless. And I think Dr. Adiga and maybe Wild might have some additional thoughts.
Dr. Dagan.
Yeah, the American College of Cardiologists, especially the pediatric cardiologists, published guidelines last month about return to athletics after infection. One of the things that they focused on is the degree of symptoms these children have had. So they kind of separated that out into serious symptoms and moderate symptoms. So if you were having fevers only for less than 3 days and no other major symptoms, there is not a whole lot of testing that they're recommending other than easing into athletics. However, if it is a serious illness that required hospitalization, then there is a lot more testing that is needed and a cardiology evaluation, including echocardiograms and EKG and all that. So it's the degree of illness that the physicians have to use to determine how much more they need to test.
Yeah, and it keeps changing because we know that a few months ago, we wouldn't have recommended some of those things. Now we are recommending them. It's harder when you have a younger child, and is everybody going to have an EKG and a cardiac MR? That's a pretty big get. So we're just, it's what we've said to our patients. We can't tell you that it's not safe. We can't tell you that it is safe until we learn more. But if you are having symptoms, clearly that's going to be a dividing line, and you got to get more checks. If you're asymptomatic and you're a young person, you're probably going to be safer. We don't know the real data about that yet. It'll be months before we really do. Jill, time for really one more question.
How can we be assured that the correct cause of death is being recorded when it is in fact a COVID death?
Boy, we have heard a little bit about that lately. Dr. Batrash, I know this is something the VA puts a lot of attention to because you guys really have probably the best single source of all sorts of patient information in the country. How do you guys record that death?
Well, in general, the death certificate, if you will, at the end is signed by a physician to determine the cause of death. If someone is admitted to the hospital with COVID and dies a few days later or weeks later related to complications, I mean, that is a clear indication of COVID being the cause of death. If, on the other hand, someone had COVID several months ago and recovered completely and now is admitted for totally something different, I wouldn't think that is related to necessarily to COVID. So this is a kind of, I think it's important to, one of the metrics that we always look at is also 30-day mortality. So in general, when someone is discharged from the hospital and passes away within 30 days, you look at, is it really related to what caused the hospitalization as well? So it's, I know it's a little bit not a straightforward answer because it's never straightforward when it comes to that. But I feel that, there's actually even a national indication that some deaths are due to COVID, but they're not reported as due to COVID. So this mortality rate is really a little bit underreported because of also lack of testing. Some of the people who are acquiring COVID and they may stay at home and they may die at home and no test was done. So that is an issue also that could result in underreporting of mortality of that. So
you bet. Dr. Steele, how are things done over at Truman on this one?
Well, here at Truman, of course, when somebody dies, they may have several diagnoses that are listed, but clearly if COVID is going to be listed on the chart, and I think what Dr. Batrash sort of said, it can be a little bit complicated. Most of the time, if they have COVID and they've died, COVID has been the main reason that they've died. And it would be kind of unusual that it's the other way around, but it certainly potentially could happen that they had COVID, were relatively asymptomatic from that, but had died from something else.
And Dr. Stewart, final thoughts from your standpoint?
Yeah, I think that if the actual cause of death, the immediate cause of death may be something other than COVID, but if COVID is the cause of respiratory failure or blood clots or whatever it is, it ought to be on the death certificate so it can be counted.
Well, Mayor Albee, I'm a lifelong Kansas City kid. I grew up in Independence, Missouri, went to Truman High School, Williams Ewell College, and Liberty, came to KU for most of my training and been here in my professional life. This is my home. And I just want to say thank you to all of our public officials who are out there trying to help keep us safe. Hopefully we've been able to add to the resolve and to the story today to make people understand the urgency that we face. We don't want to fulfill Dr. Birx's prediction for us. That would be really bad. What we really want to do is make sure that all of you stay safe. Mask wearing is hard and it's kind of painful, but I have to tell you, there's no better way to say I love you than to do it with a mask on, because that's how we take care of each other. You've heard that today, and all you have to do is look at hospitals, which are actually one of the safest places you can be right now, despite the fact they have large groups of COVID positive patients, and they're not a hotspot. And there's a reason for that. And it's nothing magical. It's not some special drug. It's all about the infection control. That's what keeps us safe. That's what's going to make sure KU Lawrence stays safe. It's going to make sure our businesses stay safe and our culture and our communities stay open and healthy and thrive. We've proven it in hospitals. We can do it. Mayor.
Thank you, Dr. Stites, and thank you to all who participated today. And perhaps the way to really kind of make that question real about the question of love, the best act of love for us, for each other now, is to wear a mask. I think the question is for each one of us to ask, who among my loved ones, my customers, my colleagues, my coworkers, neighbors, who am I willing to expose to the virus? And if I can't identify anyone I'm willing to expose, then I must take responsibility, wear a mask, maintain social distancing, and practice good hygiene. So thank you all again for those who joined us today, and have a good morning. Stay healthy, please.
All right. How was that?
That was good.
Okay.